Hi there, and welcome to today's webinar, Your Bones Matter, hosted by the National Osteoporosis Foundation of South Africa. Thank you so much for joining us. I'm your moderator for today. My name is Laura Lopez Gonzalez, and I am an independent health journalist based here in Johannesburg. My work has appeared in outlets such as Al Jazeera, The Guardian, and the Daily Maverick, where I've spent the last year writing about how food shapes us. And when we look back on the history of food, what we know about the way that people ate thousands of years ago comes from bones. How their teeth wore down can tell scientists whether they ate meat often or whether this changed as they moved from one continent to the next. The ribs and the long bones of the legs reveal times of scarcity in which the absence of fruit or other foods high in vitamin C changed the very fabric of the body and left scars that remain even thousands of years after death. In a way that no other part of us can, our bones tell the stories of our lives. Yet we still don't often think about our bones until we're forced to. More than 4 million South Africans may be living with osteoporosis, a disease that causes our bones to become weak, brittle, and prone to breaking. We know that osteoporosis affects men and women of all races, but that white and Indian women, especially older women who are past menopause, are at the highest risk. Still, osteoporosis remains poorly diagnosed and treated. Most people with the condition don't know they have it until they suffer a fracture and are diagnosed. And once this happens, they're more at risk of another break, and some can be life-threatening. Often called the silent crippler, osteoporosis causes one fracture every 3 seconds globally, leaving people in pain, vulnerable to depression, and threatening to rob them of the ability to live full and independent lives. We also know as many South Africans continue to trade more rural ways of life for big cities, changes in the way we live and eat will also increase the risk of developing the condition as we lead more sedentary lifestyles and eat less whole foods. Many people mistakenly believe osteoporosis is a normal part of aging, or that it's a condition that you should begin to worry about when you're much older. The truth is, no matter what your age, you can be taking steps to reduce your risk of osteoporosis. To hear more about what we can do, but also what our healthcare system can be doing better to prevent osteoporosis, we'll be talking to today's panel. We'll have a short discussion with our panel before opening to the floor to questions. But remember, throughout the webinar, you can use this chat function at any time to send through your questions. And I see a couple have already come through. So without further ado, let me introduce our panel. We have Dr. Zane Stevens, my apologies, is an endocrinologist who specializes in endocrinology and metabolism. He currently practices at the Cape Institute of Endocrinology, where he treats patients living with osteoporosis. Teréza Hough has been the CEO of the National Osteoporosis Foundation of South Africa for almost 20 years. She has more than 10 years of experience as a technologist in charge of bone density scans at Tygerberg Hospital, and these scans are, of course, used to diagnose osteoporosis. She is also a qualified nurse and midwife. We may also be joined later on by Thecla Macdonald, who's a patient or a person living with osteoporosis from Oudtshoorn, a small town in the Western Cape. But before we get started, we wanted to play a short clip and hear from one woman named Anne, who is living with osteoporosis.
Osteoporosis is a deterioration of the bones in our bodies. It's a slow process and one is not always aware of it. Osteoporosis can have a bad effect on your life if you don't have it treated. By not being aware of it can lead to several bone fractures that could turn your life into a misery. I am Anne, and I have osteoporosis. About 4 years ago, I fell, broke my hip, and a pin had to be installed. I didn't know exactly what to expect. Osteoporosis hasn't really changed my life. I still do all the things which give me pleasure. A month ago, I returned from a cruise to the Arctic Circle around Iceland and Greenland. My diet has changed in a small way in healthy foods, fiber, fruit, and vegetables. I do think it's important to be aware of it, to read up about it, and know what osteoporosis is. Do have the tests regularly to make sure how you should adapt to it. It doesn't deter me from socializing with friends. That's not something to be scared of. Your bones matter, and together we can fight osteoporosis.
You know what I really love about Anne's story is she talks about, living out some of these dreams that she must have had for, her whole life, sailing in the Arctic Circle, socializing with friends. And it's something that I think about as I get older about how the actions and the sort of decisions I make now really set me up to have that sort of independence later on in life as an older person. Teréza, I wanted to start with you. Can you take us through some of the risk factors for both men and women for osteoporosis?
Oh, I think there are so many of them, Laura. Chronic diseases. If you're on glucocorticoid or cortisone therapy for those diseases like rheumatoid arthritis, and Zane, you can just jump in here in any second. Diseases like cancer can cause osteoporosis, malnutrition, celiac disease. I think there are so many. And then obviously your lifestyle. Smoking, drinking, it's not good for your bones. Not exercising, bad for your bones. If you have a family history of osteoporosis, the chances that you'll get it is also quite good. Other diseases like diabetes, living with HIV. Zane, do you want to add to that list?
Well, obviously, it is more common in women, and being postmenopausal. So kind of the classic risk factors are advancing age, a postmenopausal woman, and then all those sort of underlying diseases that Teréza was pointing out contribute to that. And very importantly also is a family history. So we don't always think about this as a genetic condition, but a very big part of that is. So if you've had a mom or a dad who broke a hip at an advanced age, that puts you at a significant risk. And I think, we as doctors even used to make the mistake of saying, oh, but that's normal. If an old person falls and breaks a hip, that's just the course of life. And we know today that's not the case. That person has got osteoporosis. And if you have a family member with something like that having happened to them, you are at risk yourself.
Yeah, no, and I wanted to take a minute to thank or to welcome Thecla Macdonald, who I think has just joined us from Otseren. Hi, Thecla, can you hear me?
Yes, I can, thank you.
Hi, thank you so much for joining us. So Thecla, you have been diagnosed with osteoporosis almost 20 years ago now. Your mother also had the condition. What prompted you to start getting those tests done to check out what was sort of going on with your bones?
Well, my mother wasn't diagnosed, but she had the dowager's hump, and she was definitely shrinking. And she died in 92, so there wasn't much information online or anything like that in those days. But one day I saw an advert for calcium. It was a calcium supplement, and it was a sort of a shadow of an old lady with a sort of a hump on her back, and it just looked like my mother. And so then I decided I should go and get myself checked.
Wow. And so, and then the diagnosis came back positive, obviously.
Yes, to begin with, I had osteopenia.
Okay. And what, just explain for people who don't know what that is?
Osteopenia is the start of osteoporosis,
Okay.
the beginnings of it.
And so were you able to access treatment for the condition?
Yes, I'm fortunate. I have medical insurance, so I'm fortunate that I have treatment, although it doesn't cover everything. So
Right, certainly some gaps there that we'll talk about in a bit. But I want to ask Dr. Stevens, what does, Thecla was fortunate and she saw an advert that prompted her to go get this checkup. What does screening look like in South Africa right now, and what are the gaps?
well, I would imagine it's expensive. I would imagine. I don't know what people who don't have medical insurance, I don't know what they do. I had a bone density test yesterday, and my spine is getting a bit worse. I had esophageal cancer in 2012, and I was taking Fosamax, which is quite a harsh drug. So they took me off the Fosamax. And I had radiation for the esophageal cancer, but nobody. Well, I didn't think to go and be checked, and nobody said go and be checked. So about 3.5 years later, I fractured T8, which is a sort of a combination of osteoporosis and a radiation fracture. And I fractured that getting fit doing jumping jacks. And my oncologist, they sent me for an MRI, and then they put me on. I now have a yearly infusion called a cluster,
Okay.
which is very expensive.
Yeah, so it sounds like some definite costs of care that maybe not everyone is lucky to afford.
Yeah.
I wanted to turn to Dr. Stevens and ask, what does screening for osteoporosis look like in South Africa, Dr. Stevens?
So our National Osteoporosis Foundation actually has some guidelines that are very helpful to general practitioners for screening. So we would be advocating that every woman really at the age of 65 should have a screening bone density, and possibly even younger if that woman has got an underlying risk factor. So Thecla, for example, said that her mom had seemed to have osteoporosis, and with that history, we would probably offer that woman even an earlier screening than the age of 65. But really, we would be advocating for every woman to be allowed a bone density age of 65, and for every man at the age of 70, also unless there's a compelling indication to have that earlier. Now, obviously, we live in a country where there's sort of a large amount of diversity in healthcare. And so we would like that to be available for everybody. People with medical insurance typically do have access to that screening. Within the state health sector, unfortunately, the number of bone density machines, because that's really what the gold standard is for screening, you need to do a bone density on what's called a DEXA machine, is not freely available everywhere in the country. So that is a big gap. But that's really what we are trying to push for, because that's the way that we pick up this condition. Unfortunately, without that, many people are left undiagnosed because it's a silent disease until the day you break that first bone.
Wow. Yeah, no, always a tale of two healthcare systems in South Africa. Teréza, I wanted to ask you, Thecla was fortunate and she's been able to get some treatment. Her mother, it seems like, wasn't. What is the prognosis for somebody who has osteoporosis and who doesn't receive treatment?
Well, they'll fracture. They'll most probably have a fracture, and that is the prognosis. So definitely treatment is necessary for someone with severe osteoporosis. And unfortunately, and I think that's something Zane addressed too, about the things that curb the diagnosis or the treatment of osteoporosis patients. But I think even in the private sector, I think there are some myths that still exist within the doctors and the society, that this is a disease of old white ladies, and that's not true. So we need to bust those myths in any case. And the other problem is funding. And even if you are on a medical aid, they don't fund everything, as Thecla said. So our medical aids, because osteoporosis is not a prescribed minimum benefit, they don't have to cover osteoporosis. They cover the fractures, and something Zane discussed previously with me is we're trying to add that to a basket of care. So we'll try and get that sorted out. So I think the myths and the funding is still, even in the private medical sector, it still prevents people from getting timeliest treatment or diagnosis even for osteoporosis, because we know that even a vertebral fracture doesn't get diagnosed, and a neck or femur fracture gets diagnosed because there's no other way but to repair it. So there are so many things that can still be done, but I think the awareness about osteoporosis, even amongst our medical doctors, it still needs to be addressed.
Right.
Well, maybe
Yeah.
to add to what Teréza said there, so just to put that into numbers, so if you have got osteoporosis and you break a bone, and just for listeners out there, I always just want to make the point, because I know people always can get confused about this. When we say fracture, we mean break a bone. You know, many people think that those are different things, but that's what we're talking about here today. Once you've had one bone break, you are 3 times more likely to break a second bone. Once that second bone is broken, you are 5 times more likely to break a third bone. And the classical places would be the forearm, the vertebra, the upper arm, and the hips. And we really want to try and prevent people from breaking any bone. But once you've broken one bone, you know, as a patient, even if your doctor lets you down a little bit, you've got to try and push to see somebody who's going to consider treatment for you. And I was just thinking while Teréza was speaking, you know, I'm quite passionate about sort of empowering patients to take control of their health. And one of the things they can do is we have available in South Africa now, like the rest of the world, an online assessment of the risk of fracture. And this can be done even without a patient having a bone density in your doctor's office. And you can, as a doctor, access that online. It's called FRAX, F-A-R-A-X. This is an internationally validated tool. And you simply say yes or no to the typical risk factors for osteoporosis. You use the patient's weight, height, age, and sex, and you can determine the risk of that person breaking a bone over a period of 10 years. And if it's high enough, that patient may qualify for therapy, or you at least would be prompted to say, hang on, I need to go and look a little bit further and send this patient for a bone density. So it's a great starting place to sort of assess the patient's risk that you're seeing.
So it's definitely something somebody, you know, if you wanted to find out more about what your risk, or maybe a risk of a family member or something, you could go into the doctor's office and say, listen, I know this is available. Can we run through it? That's great advice. I just want to follow up, you know, you said basically as you get these breaks, your risk of another break increases almost exponentially. And not all fractures are sort of created equal. Am I correct? There's a significant risk of death with some, is there not?
Correct. Yeah. So, I mean, our worst outcome in osteoporosis is a hip fracture. And these tend to occur in older individuals, their 70s and 80s. And this is an absolutely catastrophic event in such a person's life. We know that statistically 20% of those people on average are no longer with us a year later. They pass away because they're not mobile, they get blood clots, they get infections. About 50% of those people, despite having surgery for their hip fracture, are no longer completely independent in terms of activities of daily living. So this impacts not just on the quality of life, but on the quantity of life. This actually leads to death. And so that's the big thing we're trying to prevent with therapy.
Yeah. Thecla, you mentioned you had incurred a fracture, or a break. Just by doing some average sort of jumping jacks. How have you kind of adapted your life after to sort of avoid another fracture?
Well, I also was lucky. I had a kyphoplasty, which is basically cement in my back, trying to hold everything up. But I also I go to exercise classes, and I use resistance bands, and I try not to do, because that's another thing. People say you must exercise, but there's not much information about what exercises you shouldn't do. And as I say, I had to research all these things myself, which I'm lucky. I'm computer literate and I'm interested, etc. But I mean, people don't know that doing sit-ups can fracture your bones, etc. So it's just little things. It's not just doing jumping and all the rest of it. So, and I don't know. When I have the cluster infusion, it would be nice if somebody gave you a leaflet along with it. Just give you information would help.
Yeah. Yeah, so and I think that's so often the case. You're a patient, you're dealing with sometimes pain, you're trying to navigate the health system, be your own advocate, and on top of this, we often leave patients to sort of figure out what they're taking and how to, all that treatment literacy on their own. You have access treatment. You said that you're lucky to have medical aid. Does medical aid cover all of your costs?
No, they don't. They don't cover the cluster infusion, which I don't know, last year was over 3,000 rand. I don't know what it will be this year. So they don't cover the bone density scan. And I've had a few other problems. I've been in hospital for other things, and I just think that the cost of the infusion is probably not even one night in hospital. So I wonder where medical aids, they're not saving. They would perhaps save more money if they just treated us.
That's true. We also often hear in healthcare that prevention is much more cost effective, right, than treatment. Teréza, you at the foundation have talked a little bit about some solutions our healthcare system could be taking to help prevent people from falling, from incurring these fractures. Teréza, do you want to talk to us a little bit about what we could be doing better to, as Thecla said, prevent these falls?
Well, the falling, I think, is basically the patient, a combination of both the doctor and the patient preventing the falls. Firstly, the doctors need to see what they prescribe to older patients in terms of sleeping medication, antihypertensive medication, things that can make their blood pressure lower. So those are the things that doctors can look for. But the patient, I think, needs to have their eyes tested regularly. I think even their ears tested, because the older you get, the more your balance gets affected. So then they have problems with that, and they fall more easily because they have balance problems. And to the patients themselves, making their homes fall safe, loose rugs, good lighting when you get up at night, loose cables. And I think once you get to that age, and I have a mother that's 85, so when I walk into her house, I start looking about where can she fall. So I think you look with a new eye, and like installing simple things like hand railings in showers or baths, simple things that you can try and do to make your home fall safe. And if you are on a list of medications, to try and get your doctor to even make them less, or to just check out all those things. And Zane is a very good doctor. He usually does that.
Is there a way, and I've heard talk of in the past treatment navigators to try to help prevent fractures, for instance. Is there something that we could be doing to try to get people onto sort of treatments to prevent these fractures once one has happened, or before maybe?
Well, I think Zane addressed that question, and Thecla too. The medications are there to prevent the fractures, but they're prescription medications. Some of them are quite costly. Medical aids don't pay for it because if they don't have to pay for the prevention of osteoporosis. They'll rather pay to have the fracture because that's what they have to do. They have to pay for the treatment of the fracture, for the hip fracture, for any of the other fractures. So that is a prescribed minimum benefit. Osteoporosis is not a prescribed minimum benefit. So they will treat the fracture but not prevent the next one. And as you heard, the chances of you suffering a next fracture without treatment doubles and triples. And the more you fracture, the more you will fracture, because a fracture begets fracture. So I think in terms of policymakers, this is something we need to address, to either get osteoporosis recognized as a prescribed minimum benefit, and that is something that I've been fighting for a long time. And it's probably not going to happen soon, but we have a few solutions that we can address that question for. But that is the thing that will prevent, active medication will prevent the next fracture. And it can prevent osteoporotic fractures by up to 70%. So that's almost a no-brainer. People need medication to prevent the next fracture.
Wow. Zane, how, as a doctor treating patients, how difficult is it for patients that you see to access the medicines that they need?
No, I think the funding is clearly the biggest challenge. We also have to bear in mind a lot of our patients who need the medication the most are at a time of their lives when finances are not easy. These are individuals in their 70s and 80s who retired at 65 or at 60 and need to be mindful about the fact that they're probably going to live to 90, and they need to think about the finances related to that. They're paying a lot of money on their medical insurance, and in my opinion, their medical insurance lets them down significantly at a time of life when they're needing preventative medication. So it's almost criminal. And through the foundation, Teréza has done a lot of work and continues to do so to try and see if we can rectify that. But as she's mentioned, there's not a lot of light at the end of that tunnel in the near future. So at the moment, what we have to do then is to offer patients the treatments and look at what is cost effective for them. But there's no doubt that the medication is cost effective from a funder perspective. So it is endlessly frustrating that they don't buy into what we can offer our patients.
Teréza, I just want to return to you, as as a journalist, I've covered this time and again with pretty much almost every condition. It feels like that you could imagine. But it seems like such a quite clear, sort of math kind of problem, right? Like if you prevent the falls and you prevent that like morbidity and mortality, it's clearly going to save lives and be cheaper than the surgeries and the treatments after. What is the biggest argument against making this a PMB or a prescribed minimum benefit? And for those of you who don't know, a prescribed minimum benefit is something that medical aids legally must cover.
I think, Laura, I think at this point in time, our government is looking at the NHS, and they've been making noises about this. So our Council for Medical Schemes, they decide on what goes onto the PMB or the prescribed minimum benefit list. And they have 20 chronic conditions on there with all the side things that go with it. But it's just not, I think we firstly didn't have enough statistics in this country to really convince them about osteoporosis and that it is really a problem. We now have that, and it's linked to fracts, and we've got fracture data for South Africa, but it's still not convincing enough. We need numbers. We need to convince them with money-wise how much they're going to save, because if you look at the global statistics about how much money is being saved in Europe, in America, with just implementing things, and we can talk about that later, fracture liaison service, but also just treating osteoporosis and preventing those first fractures. It's enormous. It's an absolute no-brainer. And as Zane said, it's almost criminal for the age groups where the fractures occur to not be able to pay for the medication to prevent their fractures, or to go or just to go to a doctor. And in our government hospitals, it's also not a very good picture, because basically the medical aids and government look to each other for what goes on to the PMB list. I can bore you for hours about my fight with the Council for Medical Schemes and the medical aids. But I think we can approach them with some other solutions, and we're in the process of doing that. But Thecla is, Thecla is probably in the fortunate position that she can pay for a DEXA and that she can pay for a medication out of pocket. But many people can't. And as Zane said, those are the older people. And because we live longer, we didn't prepare to live until 90 and 95 and even 100 years old. We thought we were going to die 10 years after they just stop working and retiring. And that's not happening. That's definitely not happening. We are an aging population. In this country, we only have about 18% of our 60 million population over the age of 50. Can you think what this is going to look like in 20 years' time when we have a much older population? And the fractures are going to double by 2050 or more than that. And if you think a fracture occurs once every 3 seconds globally, and why would South Africa or Africa be that much different to the global statistics?
Right. And we see
those are the scary ones.
Yeah, and I think you're completely right. And we see, countries like the US and many countries in Europe that have seen that aging population just not prepare for that wave, and are certainly do not have geriatric or sort of like elder literate doctors, which I think Zane has also sort of alluded to. Thecla, I wanted to ask you, once you had that first fracture, how did your life sort of change? Were you able to, did you have a family support system to be able to help you care or do kind of things around the house? And how was your pain managed?
Well, I live on my own, so I really didn't have any help. I just had to muddle through. My daughter-in-law, she's an occupational therapist, but she doesn't live near me, but she gave me some tips and things how to manage. And I was given tramadol. It didn't do anything, so I didn't take it because it actually had no effect. And at the time, I'd recovered from esophageal cancer, and to be quite honest with you, at the time when I fractured it was really painful. I could still walk, but I couldn't move my arms. It was painful. I couldn't do things, and I thought, if this doesn't get better, I think I would rather have cancer, because they can fix you or you die. It's not this continual pain.
Right.
So,
yeah. And I think we don't speak enough about how much pain, chronic pain, really takes a toll on your soul, your mental well-being, not to mention just physical. And like so many people, a lot of us move around for work, and we don't always get to live by our parents. And I think that that's another really important point you make about the importance of keeping independent. Teréza, I wanted to talk to you about something that you mentioned as a possible solution about fracture liaisons. Can you tell us a little bit more about that?
Well, it's something that it's also another thing that's very close to my heart, and also something that we're really struggling to implement in South Africa, and that's to get hospitals to implement a fracture liaison service. So what that means is that when a patient, or if a patient comes in with a fracture, say a hip fracture, get into the ER, that they're identified and then referred to an appropriate team. So they first get the fracture repaired. So they go to the orthopedic surgeon. But that means that the orthopedic surgeon needs to refer in that circle either to the physician that's interested in treating osteoporosis, but also to the rest of the multidisciplinary team, like a dietitian, like a physiotherapist. And Thecla mentioned there that she didn't get anything with regards to what exercises, which exercises, what she can do. And the dietitians and even occupational therapists. So before the patient leaves the hospital, they either had their DEXA, had an cluster or their first dose of anti-fracture medication so that we can prevent the next fracture, and then referred to when they go back home, they will get referred either to their GP for follow-up of this patient. But the patient needs identification. It needs to be identified as an osteoporotic fracture and then treated as such and referred to the appropriate people. And we also know that a system like that saves so much money because you prevent the next fracture. And this patient really gets followed up. And that's in an ideal world. So that is something that we want to implement in this country. And we've got 2 hospitals that have started. And one is Tygerberg Hospital, and the other one is Vincent Pilati, a private hospital in Pinelands. We're getting more and more interest in that. I know Zane is also very, very passionate about a fracture liaison service, but to get policymakers interested in this is like pulling teeth from a chicken. It's terrible to get them really interested unless you have numbers to tell them how much money they are going to save by implementing such. So the fracture liaison service is another dream of mine. I hope it will be fulfilled before I die one day when I'm 120. So, so those are the systems that we're trying to implement in this country. So it's not as if we don't want to do it. It's just a hard task, and it's a hard ask because we need just one interested policymaker and one hospital manager interested. And we're getting there. It's not all doom and gloom. I will remain positive about this.
Yeah, no, I think you're exactly right. Policymakers want to see those cost benefit analysis, the cost per patient, the numbers. And I think they also really want to hear from people like Thecla who can really put a face to this story. So I think, thank you so much for Thecla for making this time.
Absolutely.
Zane, I wanted to ask you, you've given us some great sort of questions we can ask, like if you're postmenopausal, if you're over 65 for women, if you're 70, you should be asking for these bone density scans. And I just wanted to touch on it. We've spent a lot of time talking about, maybe who we kind of think that the sort of typical osteoporosis patient is, and she's older, she's maybe white, and we've heard from Teréza that this really affects people across the spectrum. How many men, or do you see men in your practice for osteoporosis?
So I'm fortunate I do, and I think that's just because I'm lucky and people know that I'm interested in this as a disease entity. So it's a bit of a referral bias, but I think men are, and there's global literature to support this, are underdiagnosed. So, I mean, that sort of poster picture of somebody with osteoporosis, exactly as you described, is a postmenopausal, white, very thin female. And we know that, yes, 1 in 3 women over the age of 50 will sustain a bone break because of osteoporosis, but men are not trailing that far behind. 1 in 5 men, in fact, will sustain a fracture because of osteoporosis. If you put it in a slightly different way, over the age of 45, it is more likely that a man is going to break a bone because of osteoporosis than be diagnosed with prostate cancer. And prostate cancer is super, super common. So it is something which is not diagnosed in men because we just don't think about it. So absolutely, we need to be screening our men appropriately at the age of 70, but certain men would be at higher risk. And so the kind of risk factors we spoke about earlier apply to men as well. There's a family history of osteoporosis, if you've got an underlying disease, which we know affects bone, so those would be diseases like diabetes. And then another very important group of men are men who are treated for a cancer by suppressing their testosterone. So as with women, where estrogen is super important for their bone health, testosterone is also important for men's health. And so men these days are often given medication to suppress testosterone as a form of treatment for prostate cancer, which is becoming very important. So we call that androgen deprivation therapy. And this is a very, very important group of men who we should be screening obviously earlier because they're going to be at higher risk. So yes, we're missing our men, and we need to be screening them appropriately.
Wow, yeah, I mean, diabetes as a risk factor really applies to so many of us at this point. I wanted to take some questions from the audience. We've already gotten a couple. I'm going to start off with Georgina Schlatter from Cape Town, who says, I have severe osteoporosis affecting all my bones, but my greatest pain, and it's debilitating, is really in my lower spine with several fractures. I am commencing my 4th month of Forteo at almost 5,000 Rand per month with no assistance from Discovery Medical Aid at all. My query is, why would medical aid refuse to pay?
Okay, And I think we spoke about that, Laura, because osteoporosis is not a prescribed minimum benefit. So if you see, if she's already had a fracture repaired, and say she had and she's got several fractures, I see, they would rather pay 12 times that amount to repair the fracture, but they won't pay for the medication. And that is something that we will address, and we are going to address to see whether there's another way of getting the medical aids to realize that paying for the medication is going to be, in the long run, is going to be a much cheaper option for them. So it's because osteoporosis is not a prescribed minimum benefit.
I just have a follow-up question to that, to Teréza or to Zane. Have you had any luck, sort of fighting, the sort of appeal boards, any medical aid for patients?
The short answer, no.
No.
So because it's not a PMB, they have every legal standing to kind of refuse treatment. So essentially, currently, it is at the discretion of the funder, and only the sort of upper tiers of each fund has a slightly extended list, and they may then consider treatment. But even within those cases, it is at the discretion of the patient. They will, for example, the person asking the question here, Georgina, is on the most appropriate treatment, having had multiple vertebral fractures. And so she's on the right therapy, but some funders would not even pay for that, even if they do pay for something, because of the cost associated with that medication.
Wow. We have another question from Marty Johnson from Hermanus. What other treatments are there for severe osteoporosis if 3 Aclasta infusions did not have the desired results? I am 76 years old.
So maybe just firstly, we must be sure that what we're referring to didn't have the desired results. So we've got to remember that the treatments for osteoporosis are there to prevent the further decline in the bone density and to prevent fractures. So if on those 3 infusions, there were no fractures and the bone density remained stable, that treatment was in fact successful. And I often just have to remind our patients about that. We don't expect necessarily to see a big increase in their bone density. And if we don't, that doesn't mean the treatment has failed them. I think the other thing that's so important to realize is that osteoporosis, like high blood pressure or like asthma, is a chronic disease. It's not something that we can cure. And once patients have been diagnosed with osteoporosis, they are probably going to require various treatments on and off throughout their lives. And what Marty had is a typical course of 3 of these once-a-year infusions. And at the end of that course of therapy, we really need to make a decision about how high is the risk of fracture now for this individual patient. And perhaps we've reached a point where that risk is not that high anymore, and we can pause treatment. We used to say we put patients into a drug holiday. We don't like that anymore because people go on holiday and they never come back. We pause their treatment and we watch the bone density, because it's likely that in a couple of years' time, their risk of fracture is going to go up again and they will need further treatment. But there are treatments that we can give after that 3 years of treatment if that person needs ongoing treatment immediately. And she needs to just discuss that with the treating doctor, but we have injections, which we give every 6 months, which would be a very good follow-on to that. But we've got to look at it at a case-by-case basis. But the point is, it's a chronic disease. We're not going to cure it, and we may be able to take little breaks, little pauses in treatment, but further treatment is likely down the line.
I think, yeah, so much of what we've talked about too is sort of a treatment literacy. What does it mean for something to be effective? What should I be doing? Teréza, what kind of resources? Thecla seems like she had to find this out kind of on her own. She was lucky to have a daughter-in-law in the medical field. What resources does the foundation offer for people who could be at risk or are living with osteoporosis?
Okay, so we do have a very informative website. We have monthly blogs on topics. Just simple things like full risk or any interesting topic on osteoporosis. So what causes it? Where can you go? The other thing is we have if they go onto our website, we have a list of referring doctors, or they can call us for that. We have a separate section for doctors to educate themselves about osteoporosis. But most things on osteoporosis, and that's what the foundation is primarily here for, is patients can call, they can go on the website. We have a Facebook with a support group at this point in time where you can ask your questions and we can get back to you with an answer. So we've also increased that. We weren't that really social media active 5 and 10 years ago, but I think post-COVID, or even during COVID, our footprint, our social media footprint has definitely deepened and increased, and we've got more interactions with patients. So we have, and the other thing is, we're also a full member of the International Osteoporosis Foundation, who have wonderful content on every topic. So we post most of that, but patients can contact us, and we've got a helpline, and we on LinkedIn, we're on Twitter, we're on Instagram. So we're really on social media platforms. So even if you're not that social media or computer literate, you can literally just phone the foundation and we can point you in the right direction.
Great. So you don't have to take us on and sort of figure everything out yourself. There's definitely resources out here,
yes,
and authoritative resources.
And then we can post it to you if you don't want to go online, or if you don't think that you can go online. But I think we're really underestimating our silver surfers, because they, I think even with COVID had to have some pluses, is that people started spending time in front of their laptops or computers, or trying to make themselves computer literate. So we've definitely seen an increase in our, what I call silver surfers, contacting the foundation via our various social media platforms.
That's great. We have another question from the Ndiwe Manare in Johannesburg. Why do we not have as much information about osteoporosis at clinics as we do about other diseases like HIV and diabetes? Zane,
You have them soon.
So the Ndiwe, it's coming. It's coming.
And the Ndiwe, it's coming.
Great. I have another question. Oh, go ahead, Zane.
No, I was going to say, I think one of the things, unfortunately, is just policy about the PMB status. So it's not a priority for policymakers. But another thing which is a little bit sad to me is that osteoporosis training in medical schools is probably not what it used to be. Our doyen is no longer with us. And not all medical schools, include this to the extent that I feel that they should. So I think doctors are not as sensitized to this disease as they should be. But, that's something that we also want to kind of work on from the foundation, is to kind of just look at curricula at medical schools and make sure that this is covered in depth, because, to Tereza's point, our population is aging, and this is going to be something that's going to become very much part of what we're going to be dealing with as doctors in the future.
Yeah, and medical education is so important for setting those values as people coming into the profession. There's another question. Hi, my name is Jeannie. I'm 59 years old. I'm recently diagnosed with osteo, not due to a break, thankfully, but due to a bone density scan for persistent back pain. I am postmenopausal and would like to know what affordable options are available to me to prevent further deterioration.
So I think it's quite difficult to kind of just give an answer here, but I think what we really need to be looking at is sort of, for that person, what is their risk of fracture? And that's got to do with their age, their other clinical risk factors for osteoporosis, any other diseases they may have. And I think I want to make the point here, maybe more to doctors on the call than patients, but when we diagnose somebody with osteoporosis, before we decide about a treatment, we need to do a little set of baseline tests that we are certain that there's no other underlying disease causing this person's osteoporosis. So for example, if your thyroid is marginally overactive, it's going to cause the bone to be broken down more quickly. And if we can treat the underlying disease of the thyroid, we will impact positively on the bone. So we always want to make sure that that happens at the baseline. And then putting all of those factors together, we're going to think about the most appropriate treatment for this patient. And for example, in a young person, it might be a consideration about hormone replacement therapy. As if the person's a little bit older, there's this family of treatments that Thecla was on. She was on a tablet called Fosamax, which is an oral medication. There are generics of that available now, which are more cost effective. And there's this once-a-year infusion. So there definitely are options, and it all has to do with what the risk is of this patient breaking a bone, and we kind of decide what the most appropriate treatment is going to be based upon that.
Okay, there's another question. I have a feeling this might also be a Zane question. 59-year-old, it's from Shireen, 59-year-old colored female, had a bone density scan about 4 years ago when I had a full hysterectomy, diagnosed with osteoporosis and osteopenia, which, as Thecla just mentioned, is sort of the beginning stages, I guess, of osteoporosis. Not one doctor, Shireen says, has prescribed any medication. What medication can I use, and do I need a prescription?
So it sounds like she would need a prescription. Within the first sort of 5 years after a woman becomes postmenopausal, 5 to 6 years, if she's also suffering of any symptoms of menopause, hot flushes, night sweats, those kind of things, perhaps then hormone replacement therapy as a discussion point would be something we would be considering. But then all of the other typical osteoporosis drugs also become an option. So again, it really depends on a number of factors. But in younger individuals, so maybe just a point, every drug that we use for osteoporosis, we have a specific amount of time that we can safely use that medication. And so we want to also be mindful about the fact that we've got a 20 or 30-year game plan ahead of us. And so on the one hand, we don't want to treat patients unnecessarily. So if their risk of breaking a bone is currently not very high, we might say to that patient, for the moment, we're going to think about lifestyle interventions like weight-bearing exercise, adequate calcium and vitamin D supplementation, and watch what happens to the bone density. Or we're going to think about hormone replacement if it makes sense in that patient and there's no reason not to be using it, before we would start any other medication. So yeah, it sounds complicated. I'm probably making it more complicated, but it's not that easy without all the facts to kind of give a final answer about what treatment is the most effective in that person.
Right. So we heard some real. Oh, yeah, Teréza, go ahead.
Sorry, no, I just wanted to jump in there because it's very difficult to really say anything about that if you don't have the bone density results or any of the risk factors. Yeah. So that's basically what Zane is saying there. So yeah, she needs to see someone with their bone density.
Great. Yeah, some very practical go and do sort of information. Hearing that there's not a cure for this, but there are some treatments. The timing of your treatment is really going to vary depending on sort of what's going on with you as an individual patient. I have one last question I'm going to squeeze in here from Allison Smith. She asks, does taking collagen help to strengthen bones? There seems to be differing opinions.
Zane, I'm going to leave this in your capable hands.
So it's quite an interesting question. Look, I don't want to unnecessarily promote the use of collagen. It is quite expensive, and I think that when finances are important, I would rather spend money on other things like the drugs that we have evidence for. And if you'd asked me this question 2 years ago, I would have said there's no evidence. There was one, and I want to say it was a very small study that was published towards the end of last year that showed that quite a high dosage, it was 5 grams of a hydrolyzed collagen over a 12-month period of time, was able to show that on a bone density that there was improvement in the bone density. Now, it was very small, and we don't have any data to show that this prevents fractures. So every drug that we use in osteoporosis, we know has been proven to prevent people from breaking bones by a specific percentage. And we don't know that about collagen as yet, but we've got some early work to show that it might improve the bone density. And I want to emphasize the might. So I certainly don't want everybody running out to buy collagen because they think it's the be-all and end-all for their bone density. But to be fair, there is a little bit of evidence to show that it might be beneficial.
That sounds like quite a high dose, probably higher than you're getting in the sort of over-the-counter sort of things.
Correct.
One last question from Petra Vandermeer. What would be adequate calcium and vitamin D intake?
Well, okay, I'll jump on that bandwagon. So an adequate calcium, as we say, roughly about 1,000 milligrams per day, preferably from your diet. If you can't get everything from your diet, combine that with a calcium supplement. And we don't want you to take more than 500 to 600 milligrams of supplement per day. And take that in smaller doses during the day. And depending on what type of supplement, you need to see what time of the day you should take it with a meal. It's usually with a meal because most of the supplements are calcium carbonate. And then vitamin D, I think there are conflicting things about vitamin D. But Zane, would you say 600 to 800 IUs per day?
Yeah, I think that's reasonable. You know, there's been some recent literature that kind of tried to or suggested that it was not all that important, but I think you've got to be careful with all studies. You've got to look at who were the people that were looked at in that study and is it answering the question. And I think it's to me, and this is, I know this is anecdotal, but in our practice, when we screen patients with osteoporosis and we look at what their vitamin D levels are, we have very low levels of vitamin D in South Africa. Remember, these are older folk. They spend most of their time indoors, covered up, so they're not spending a lot of time out in the sun. In South Africa, we don't eat a lot of oily fish. We're meat eaters in this country, so we don't have a lot of dietary intake of vitamin D. And so at those kind of replacement levels, we know we're doing no harm. And the potential of doing good is pretty high. So yeah, 600 to 800 units of vitamin D a day would be what we'd be aiming for.
Great. Well, thank you so much. We're going to wrap up now, but I just wanted to give everybody one quick opportunity to sort of say their final message, whether that's to policymakers or doctors or to fellow patients before we close. We did run a little bit over, but the Q&A was just so great. So Teréza, do you want to kick us off?
Well, I think I've done my bit about policymakers and I'm getting tired of that, but I want to give this message to patients. It's never too late to start looking after your bones, and you're never too old to start with treatment. And I think that's what I hear such a lot of here. Doctors said, I'm too old to treat my bones. So you're never too old and it's never too late to start looking after your bones. Your bones do matter.
Great. And Zane, do you want to add anything?
Yeah, I mean, I think I concur with Teréza. For me, it would be if you have broken a bone, which is unfortunately already quite late, but if you've broken a bone, even if your doctor, when you're in the hospital, doesn't talk about that, let the penny drop that something's wrong here and seek out a doctor who will help you come to a diagnosis of osteoporosis and get you onto appropriate treatment.
Great. And Thecla, thank you so much for sharing your story. What would be your advice to other people living with osteoporosis?
I try to tell everybody to go and have their bones checked just once, just to see where they're at. But I go to a gym class and there's a lot of the ladies who don't even know what osteoporosis is, and that quite shocks me.
Right. So a lot more awareness needed, a lot more people telling their stories like you have today. Well, I think we've heard today that no matter what your age, there are steps you can be taking to help safeguard that independence, those dreams that we've heard, from that video that Anne sharing her story with us. And that like many struggles in healthcare, we need to be fighting harder to ensure that the chance of a dream of healthy bones in our future is also an equitable one. I wanted to thank you for sharing your time with us and to our panelists. To find out more about osteoporosis and the Your Bones Matter campaign, you can visit the Foundation's website at osteoporosis.org.za. Thank you so much and have a great afternoon.
Thank you.